So this is the legacy those of us in mental health have inherited from the leading theorists in the field. And I think there's still echoes of that in our textbooks and theory and so on, even though the field has changed dramatically in the last 10 years and has become much more open to religion and spirituality. And I think that's why we're seeing a movement like this be able to get some traction. So this was what Stan and Christina Groff proposed for spiritual emergencies back in like 1980, and defined it as a crisis related to sudden spiritual emergence during which the process of growth and change becomes chaotic and overwhelming. In such episodes, individuals often suddenly and dramatically enter into new realms of mystical and spiritual experience. However, they may also become fearful and confused and have difficulty coping with their daily lives, jobs, and relationships. And of course, some places have set up environments like ashrams and centers and so on for people to do the kinds of intensive practices that induce these very intense mystical and spiritual experiences in a way where they're protected and sheltered. And I particularly looked into this in the Zen tradition because the Zen tradition really is puts people into these very stressful situations where they have to, work on a koan for like 18 hours a day, so they're getting sleep deprived. They're not allowed to move for hours at a time, which is very stressful on the body. And they do sometimes have these incredible breakthrough experiences, these Kensho, enlightenment type experiences, but then they know, the Zen masters there know how to work with those. And one of the things they know how to work with is the inflation that often occurs when people have these kinds of breakthroughs. So as you saw in my situation, the first time I had this kind of a spiritual experience, I thought I was like the first person in the world to have this. And that this was just so wonderful that it was my mission to share it with everybody and so on. And this is a type of inflation. And it's actually relatively common in people who have these kinds of breakthrough experiences. So in the Zen tradition, they actually talk about the stink of enlightenment. And they have these little pithy sayings like, before enlightenment, you chop wood and you carry water. After enlightenment, you chop wood and you carry water. No big deal. And there are accounts in the Zen tradition of people who have these breakthroughs, and the Zen master, acknowledges the experience as valid, as a genuine Kensho experience. And in the Zen tradition, you actually get a calligraphy saying this. But then, that individual is told that for the next 6 months, their job is to work in the garden and shovel the shit in the stables to get grounded again. And there are some accounts of people like Jack Kornfield who have had people in their meditation retreats going off the deep end in this fashion. And Jack Kornfield, being both a psychologist and a very experienced meditation teacher, has also worked with individuals, helping them to integrate their experience by doing things like working in the garden and stopping their meditation practice for a little while, doing other things to help them to integrate that kind of experience. So then they started Zen it was initially at Esalen, and then it moved to my school back then. It's called the Institute of Transpersonal Psychology, and it had a hotline. There were people like Ram Dass who donated their time for fundraisers for that group, and I was involved in some of their conferences. We had 500 people at the conference in 1989 where Francis Liu and I then took on the role of, in our post-conference session, figuring out, well, where do we go from here? We just had this successful conference, but are we just preaching to the choir here, which is a question we should be asking? And how do we get this awareness out into the world? And yet, at this point in time, it remains a outdated website with outdated referral names on it. In the United States, in Germany, it has been very successful and ongoing for like 30 years. In the UK, they have a very vibrant spiritual crisis network. And as I think I mentioned yesterday, in Amsterdam, with support from the Theosophical Society and the University of Leiden, they are also starting up a new SEM for people in the Netherlands. And one of the rationales for this is that often when people are in this experience, I mean, they can feel quite overwhelmed and confused and a bit dazed by all of these new things that are happening. But the only time it becomes difficult or horrific is if they end up in a setting like a psychiatric hospital. And there's a number of case studies of this where the most subjectively frightening aspect of people's experience was the psychiatric hospitalization, not the experience itself. And we are seeing more and more people, I think, traversing this territory. Mine was triggered by LSD, but similar experiences are triggered by intensive meditation practice, intensive yogic practice, people who decide to go on fasts by themselves, Qigong. There's a category list described in the DSM for Qigong psychosis. It's actually in the Chinese equivalent to the DSM. It's well known in China, and there are several articles written by Chinese psychologists about this phenomenon. And it's listed in the DSM in the cultural syndrome sections. So people can, well, I'll read her quote, whereas spiritual masters have been warning their disciples for thousands of years about the dangers of playing with mystical states, the contemporary spiritual scene is like a candy store, where any casual spiritual tourist can sample the goodies that promise a variety of mystical highs. And I think I'm all for people putting, and I have purchased some, Qigong and Tai Chi exercises on DVDs so people can do them at home. Yoga, people often do on their own without, the guidance of a teacher. That is fine for 99.99% people. But every once in a while, somebody starts tapping into the kind of energies that these practices are supposed to release, but it can be released in a kind of a flood of energy that can be overwhelming to the individual. Now, a teacher, as I mentioned in the Zen tradition, would know what to do with that individual. But if somebody's doing this all on their own, they could get into some serious trouble. So I just wanted to mention that both Francis Liu and I were active at the time of this, and I'm still very active, in the Association for Transpersonal Psychology, because up until very recently, talking openly about spirituality in academic and healthcare settings was pretty taboo. And I found when I was starting to do this kind of work that really was only at the Transpersonal Psychology conferences that I could talk openly about spiritual emergencies and spiritual practices. In my doctoral dissertation, I taught the patients at KMVT Hospital meditation and yoga and so on. And that was another topic that was very taboo. Even though I published about this and so on, I found that once I was on the faculty at UCLA, I had no opportunity to either work with patients using those techniques, or even talk about that work. So transpersonal psychology starts with that assumption that individuals are essentially spiritual beings rather than a self or a psychological ego only. Okay, so then, as I mentioned, after this successful conference with 500 people, Francis Lou and I took on this task of a DSM category. And, we spent several years reviewing the literature and coming up with our rationale for including this category. And so our argument was that it would improve diagnostic assessments by making an appropriate distinction between spiritual and religious experiences, even ones that are very intense and disruptive, and mental disorders. That it would reduce iatrogenic harm, where people get medicated or hospitalized without actually needing that. It would stimulate clinical research, which in fact it has done in this area, and it would encourage clinical training, which is also done in this area. And one example of that, this is we published this as an article, which is on my website, in the Journal of Nervous and Mental Disease. And that actually was pretty crucial, because when we wrote up our review of the literature on this and submitted it to the Journal of Nervous and Mental Disease, there was about an 18-month cycle between the time you submitted an article, revised it, got the feedback from the reviewers, revised it, resubmitted it, and then it was accepted and put into the queue for publication. That was an 18-month process, and they've tried to shorten that now in academia, but the editor realized that if our article went through that normal review process, it would come out after all the decisions for the DSM-IV had been made. So he fast-tracked it for publication, made it the lead article in November 1992 issue of the Journal of Nervous and Mental Disease, knowing that the final meeting of the DSM-IV task force was in December, and that our proposal was one of the things they'd be considering. So having it published as the lead article in this major journal was definitely one of the factors that contributed to the DSM task force taking it seriously. So this is the category as it was accepted. So they did change the wording a little bit. I'll mention the how in a minute. And they gave it the category V62.89. This category can be used when the focus of clinical attention is a religious or spiritual problem. Examples include distressing experiences that involve loss or questioning of faith, problems associated with conversion to a new faith, or questioning of other spiritual values which may not necessarily be related to an organized church or a religious institution. Now, that's very close to what we proposed, but in our proposal, rather than mention questioning of other spiritual values which may not necessarily be related to an organized church or religious institution, we had actually specifically mentioned mystical experiences and near-death experiences. Just as we had done with religious problems, we wanted to give a couple of concrete examples, and that they removed. And I'll show you what we've done in our proposal for the DSM-5 in a minute. And I must say that when that was accepted, there was an article in the New York Times and San Francisco Chronicle. They did a piece on it on NPR, and the American Psychiatric Association newsletter had an article on it. The American Psychological Association magazine had an article on it, and so on. So it was recognized as a kind of breakthrough in the recognition of religion and spirituality as related to psychological practice. Now, I want to just mention that I think the acceptance of this category was part of a trend that was happening in the field. it wasn't divorced, it wasn't just coming out of left field. That in fact, if you look here, number of articles on religion, it has been steadily increasing since 1980. And the same with spirituality, which is, if anything, undergoing an even sharper increase. So I think to a large degree, we were kind of riding the crest of this wave. But as a result of these publications, we were able to demonstrate that, in fact, we now know that rather than the way Freud viewed religion and Albert Ellis and D.F. Skinner, that actually religion and spirituality are overwhelmingly beneficial for people, that they're associated with prevention of mental and physical illness, improving how people cope with mental and physical illnesses, and facilitating recovery from mental and physical illnesses. I used to, and I wasn't the only one, but give presentations for grand rounds at places like Langley Porter and UCLA and UC Irvine and so on, explicating this. Like I had about a 90-minute PowerPoint of just study after study after study. I think this is so well accepted now. There's so many books and so on documenting this that I don't feel I need to spend a lot of time making this point anymore. But so I just have one slide on it now. But it's really, like, say, incontrovertible at this point that these are religion and spirituality should be viewed as resources, as sources of resiliency and strength for our clients, rather than as signs of neurosis and that they had been viewed as. And another sign of this change is, like, in 1998, JCAHO, Joint Commission on Accreditation of Healthcare Organizations, in every hospital from Stanford to my local Petaluma Valley Hospital, but also hospices and many outpatient clinics as well, have to go through a JCAHO accreditation in order to get insurance and federal funding. And JCAHO now mandates that there be a spiritual assessment in every patient's chart. So now we've gone from a point where, like when I was in graduate school, I was told that if a patient wanted to talk about anything pertaining to religion or spirituality, that we should refer them to a religious professional, that was outside of the purview of our mental health practice. Now, as a result of it being in the DSM, as a result of expectations like groups like JCAHO, it is within our purview. It's an expectation that we will cover this as part of our intakes and so on. In fact, I've gone through the planning phase with LA County, and starting in December, we are rolling out training for a 3-day workshop, spread out, not 3 days in a row, but 3 separate days for over 2,000 of their staff on spirituality and religion. And 1 full day will be spent training them on spiritual assessment. So we really don't have good data on how frequently people have religious and spiritual problems, conflicts, experiences that they find overwhelming or disruptive. But this is one, I think, example of just how common they likely are. In a survey of students going to see their counselors at a student counseling center, about 1/3 were seeking help. Of those seeking help were experiencing some distress from religious and spiritual problems. And those students who were struggling with religion and spirituality were more likely to be homesick, suicidal, victims of sexual assault, or distress over a breakup. So, that's at a student counseling center, And as I say, we don't have good statistics on, in the general population, how frequently they are. But I think it's some indication that they're not rare things that people bring up in therapy. And this is one example of people questioning their religious or spiritual beliefs. When people were asked if they have ever experienced things like believing or wondering whether God has abandoned me, or feeling that God is punishing me for my sins. As you can see, somewhere between 15 and 25% of people in the general population report having those kinds of experiences. In addition, we know from Gallup polls that people can have a range of spiritual experiences that they may find disconcerting or have difficulty talking about with other people. Half of Americans believe in psychic or spiritual healing and ESP. A third or more believe in haunted houses, possession by the devil, ghosts, telepathy, extraterrestrial beings visiting Earth, and clairvoyance. And also the incidence in Gallup polls of mystical, near-death, psychic, and alien abduction experiences have also increased. And I'm going to show you at least one such statistic in a minute. Okay. So we've done some continuing work on types of religious problems, things like changing denominational membership, intensification of adherence to beliefs and practices, loss or questioning of faith, new religious movements and cults, or serious internal illness. For many people, they're not religious and spiritual issues. There's a loss of faith culture. And this is a very American phenomenon. I'm afraid this is Alfeder's and Padre Estelle and I are setting up our own little religion. And Americans are very, more than I think people in almost any other part of the world, like to form their own little religious groups. This is one statistic that 23% of people felt that their illness was a result of their sins. And that belief, by the way, is associated with higher mortality and morbidity. So this isn't just something that we as mental professionals should take lightly. Anybody who holds a belief like this is actually putting their life at risk in terms of the effects on their system. If they're actually challenged by an illness, it's going to make the illness exacerbate. So this is an early list of Stan and Christina Groff's of types of spiritual emergencies. And I've gone ahead and, based on literature reviews and so on, truncated that list to this visionary spiritual experiences, including mystical experiences, near-death experience, psychic experiences, and alien abduction experiences. A second category of spiritual problem are spiritual practice-related experiences, that Qigong psychosis I mentioned earlier, or associated with meditation, or yoga practices, and so on. And then something we're seeing in many immigrant populations are possession experiences. So I think what I want to do is show you just show you this. This is the percentage of people reporting mystical experiences, and how that has been dramatically increasing, 27 to 67%. And then, since I mentioned these, I don't need to go into those. Well, I think I do want to mention this, that one of the best ways to tell that somebody can be treated from this kind of more alternative perspective is if there are good prognostic signs present. Like, was the person showing good pre-episode functioning before the episode? Was there an acute onset of symptoms? Was there a stressful precipitant? Is there a positive exploratory attitude toward the experience? And is there absence of conceptual disorganization and confusion? So let me go ahead then and show you, I worked with a group of people associated with the DSM. We were a subcommittee, not of the task force, but of another group of the DSM. And we met for 2 months, a group of us, and we produced this book published by the American Psychiatric Association called Religious and Spiritual Issues in Psychiatric Diagnosis. And Francis Liu and I worked particularly on religious and spiritual problems, and this is our proposal for the DSM-5 revision of our category. This category can be used when the focus of clinical attention is a religious or spiritual problem. Examples of religious problems include distressing experiences that involve loss or questioning of faith, changes in membership practices or beliefs, cults, or life-threatening and terminal illness. Examples of spiritual problems include distressing experiences involving spiritual phenomena, practices, or beliefs, anomalous experiences, and I'm using that to cover mystical and near-death, psychic, and other unusual experiences, possession experiences, or questioning of other spiritual values which may not necessarily be related to an organized church or religious institution. So that was the proposal. We've been in dialogue with the task force, but we haven't a final answer. But the fact is we are in dialogue, and they're taking our proposal for that seriously, and it seems very clear that there will be a continuation of this category in the DSM.